Thanks very much. So I have no disclosures related to this presentation. So in general, with access site selection, if you have the benefit of having preoperative CT or an MRA, that actually is incredibly helpful. Unfortunately, in the real world, oftentimes these are patients who were put on our schedules and we're sort of doing ad hoc interventions. But by and large, we do angiography from the retrograde common femoral artery access, contralateral to whatever the more symptomatic limb is in the absence of pre-procedural imaging. But the location and the nature of the lesion, in my mind, are the primary determinants in which access site I choose. So in general, if it's a common iliac artery stenosis, I'll usually go retrograde ipsilateral common femoral. If it's an external iliac stenosis, I'll usually go up and over. If it's a proximal common iliac occlusion, then I usually like to approach those from above, either from a radial approach or from a brachial approach. And if it's an external iliac artery CTO, if the bifurcation is reasonable, then it's easy to just go up and over as opposed to having to work from the arm. And certainly if a patient has had a prior aortal bifem, EVAR, or kissing stents or tortuosity, then it's perfectly reasonable to come from above as well. So in my mind, no matter which access you choose, you should always do it with ultrasound. And radial artery obviously is pretty much the standard of care in the cath lab, but for peripheral interventions, it does offer some potential advantages. Obviously, there's less risk of vascular complication, patients get up earlier, shorter length of stay. The disadvantages, of course, are that you are limited in your vessel size, and radial arteries can go into spasm, especially when you're putting larger sheaths in there. But the real limitation has been limited lengths, both in terms of sheaths as well as wires, balloons, and adjunctive stenting. So if you're going to think about doing an iliac intervention from a radial artery, you got to make sure you measure your distances. And I mean, we'll literally measure them to try to figure out if our equipment's going to be long enough to reach, because it's a little embarrassing if you then have to stick the patient higher up in the arm, for example. The Terumo folks have really been trailblazers with this concept of trying to blaze a trail from the radial to get down to the peripheral vessels. They have dedicated longer sheaths and wires and balloons. But in general, remember pharmacology, use a lot of vasodilators, long sheaths. In general, diagnostic angiography is performed with long pigtails, multipurpose and vertebral catheters, and really long wires. I actually like to use 300 centimeter wires whenever I can. So let's just jump into a few case examples. This was a patient who had a previous stent in the iliac artery. This was done from above with a radial approach, and it was 300 centimeter supercore wire, 110 centimeter shuttle sheath, stiff glide wire, and then angioplasty and subsequent restenting of that ISR with a very nice angiographic result. So this is a patient who presented with severe right leg claudication, and you'll see that we initially got access on the other side, and then lo and behold, find out that this patient had an iliac CTO with a subtotal stenosis rear at the origin. So the question is, how would you approach this? Right retrograde, common femoral, left up and over, or should you come from above? Well, we decided that we would try initially a retrograde axis, but you can see that our wire is subintimal, so that probably wasn't the best idea. And then we thought, well, maybe we can try coming up from above, but there really just was not any purchase available. So we took our medicine and then finally delivered a sheath from above, and we're able to get that actually quite easily. And then at that point, we exteriorized the wire using a quick capture device, and then just ballooned it and stented it with a couple of kissing iliac stents at the bifurcation, and then self-expanding stents, and eventually we were able to get a very nice result. This next patient was an obese gentleman who had had prior attempts at traversal of an external iliac artery occlusion, had a lot of other comorbid conditions, was not felt to be a very good candidate. So you can see he's got this external iliac artery occlusion disease and is hypogastric, but below the inguinal ligament, vessels actually don't look too bad. So again, how would you approach this? We did place a sheath retrograde, knowing that we likely would need to have that as a bailout option, but we used a soft angle glide wire and a quick cross to get our sheath up and over. So we were able to get a 7 French sheath up and over and then traverse the occlusion using a crosser in the hopes that that would allow us to be intraluminal. And then after crossing, it became a relatively straightforward procedure with PTA and stenting of that external iliac with a very nice angiographic result. This next case was a patient who had severe claudication that had progressed rather significantly, and there was some evidence of iliofemoral inflow disease. And sure enough, when we came up and over, there was an occlusion of the external iliac there, and it was really down to the level of the common femoral. So again, the question is, how would you try to do this? Well, ideally, we would try to do this from above, but we really couldn't identify any obvious stump there. So we performed ultrasound-guided access of the common femoral and purposely sent the wire up the deep iliac circumflex to sort of anchor ourselves in there, and then we're able to traverse it retrograde with a crosser from the ipsilateral sheath. Again, after confirming intraluminal position, went ahead and then just fixed this from above, and again, a very nice result. This was a patient who was referred by her vascular surgeon for stage carotid disease, but also had claudication, and the carotid went out the window when she had this kind of anatomy. So we tried to get through this retrograde. We were unsuccessful, and so we basically took our medicine. We came left up and over, but unfortunately there was a flush occlusion there on the right as well. And so the question was, well, now what do we do? Well, there was what we thought was a fairly reasonable stump there, so we put a morph catheter. We're able to get a very stable position there, and we're able to pass a glide wire and cross an antegrade. We snared the wire to make sure that we're in a good position, and then at that point it was a relatively simple matter of just putting a balloon expandable stent for the common iliac and self-expanding stent for the external, and then finally kissed it with a couple of common iliac stents at the end with a very nice result. My last case is a patient with severe buttock claudication, subsequently found to have this fairly long iliac occlusion. This case, we decided a priori we were going to come from above, so we placed a 7 French sheath brachially, used a 14 crosser to get through that. We're able to take care of that very nicely. And then with some adjunctive stenting, of course, and then kissing stents at the end, we're able to get a very nice acute final result. So in summary, I think you should always use ultrasound guided access in a micropuncture kit to get access no matter where you are. Preoperative imaging obviously is very helpful. But as I mentioned at the beginning, the location and the nature of the lesion really, in my mind, determine where you're going to go. Again, if it's a common iliac artery stenosis, retrograde ipsilateral, or from the radial approach, external iliac artery stenoses, again, you can come up and over, or potentially can go from the radial. Proximal iliac occlusions, however, I think a best approach from an antegrade approach, either brachial or radial. I tend to go more brachial with a CTO because I want to have the bailout if I have to put a covered stent in. And obviously, external iliac CTOs usually approach from an antegrade access as well if there's an EVAR, previous iliac stents, or tortuosity. Thanks very much for your attention.
Thank you, Dr. Soukas. We'll move on to Dr. Soukas, who will speak about step-by-step approach to crossing aortic occlusion approach and the role of IVUS.
Thank you very much.
Very nice.
It's a great honor to be here to present my presentation. Let's move on to my slide. This is my disclosure. Before talking about topics, as you know, the primary patency after the successful stenting is very, very good. Very, very good. At 5 years, more than 75 or 80% of the primary patency was observed. I will show the case, 49-year-old male who had bilateral claudication. The focal short occlusion was observed, the abdominal aorta. I put a stent like this, so 3 years later, no stenosis was observed. So also, how should we approach this patient? As Peter mentioned before, that I tried to perform from the radial access like this. I inserted the destination 150 centimeter was inserted from the radial access like this. then I think it's very useful and helpful to avoid radial exposure. So you can insert the seal from the operator and the machine like this. So also after the procedure, the hemostasis is very, very easy like this. After that, the patient can going back to the ward on his own foot with no claudication. I want this patient to say, oh, amazing. So no claudication. What's going on? What's happening? But he never say that at the discharge. So I want to say that. Anyway, okay, let's move on. How are the much more complex lesions, such like high aortic occlusion like this? So initially, I put the self-expansive stent like this. So also, the important thing is dual lumen stent placement by using the IVUS. So if you can successfully putting the dual lumen stenting, then here is the initial result. Initial result is undilated self-expandable placement was observed. However, naturally, gradually, 1 month later, self-expandable stent was dilated together. So they makes a big aorta like this after 1 month. So 5 years later, so the good patency was observed like this. So, in the vascular field, for especially the aortic occlusion, the role of IVUS is very crucial, I think. The first, so IVUS teach us the lesion characteristics like a calcified lesion, the calcified location, or the characteristics of the plaque, so thrombolytic plaque or soft plaque or hard plaque, including the calcium. Or after the guide wire passage, IVUS teach us the guide wire, where the guide wire is passing, so subintimal or intraluminal or partially subintimal or near close to the adventitia. Finally, the IVUS teach us the standing situation, the position after the standing, and the shape. The shape is very important for the aortic occlusion, especially bifurcation occlusion site. Because if you can put the balloon expandable stent, not self-expandable stent, balloon expandable stent at the terminal aorta, as you can put like this. I put the covers the VVX from like this. In the aorta, VVX is a position where it's observed like this. So restenosis rate is very, very low. Therefore, it does not matter for many patients. But I care this situation. So hopefully, I like to make a D shape from the one. How do we make the D shape? I'm sure that. Initially, after the successful guide wire passage, you put the VVX stent like this. Then, much bigger size balloon, maybe 80% of that aortic diameter, from the proximal side, like this, from the secondary. Then you can put the so kissing balloon technique was performed with the optimal balloon size of the iliac diameter. Here is the result. We will check the IVUS. We will check the IVUS like this, the D shape or not. And you can see, here is the aorta, and then here is the external iliac. And you can see that we can succeed to make a D shape. I summarize again. Initially, you put the kissing balloon technique like this in the aorta like this. Then, bigger size balloon was ballooning was performed like this. Alternatively, on the other hand light, then kissing balloon technique again. Then you can easily make a D shape like this. Therefore, so for the aortic occlusion, the exercise, the IVUS is very helpful to avoid the complication and to keep the good patency. Thank you very much.